My name is Cynthia Ko, and I am a gastroenterologist at the University of Washington. In this clinical practice update, we discuss what endoscopists need to know about assessing polyps during colonoscopy and choosing appropriate polypectomy techniques, focusing on polyps 2 centimeters or less in size. To choose appropriate polypectomy techniques, endoscopists should be familiar with optical diagnosis schemes such as the NICE classification, WASP criteria, and the Paris classification to predict polyp histology, identify lesions with suspected submucosal invasion, and identify polyps that should not be resected endoscopically. The field is moving towards expanded use of cold resection techniques due to their improved effectiveness and safety profile compared to hot techniques. Cold snare polypectomy is the preferred technique for small polyps defined as less than 10 millimeters in size and can even be used for small pedunculated polyps with thin stalks. Hot snare polypectomy has inferior complete polypectomy rates and a worse safety profile for small polyps compared to cold snare and should not be used. In selected cases, cold forceps polypectomy with a large capacity forceps can be used for 1 to 3 millimeter polyps that are difficult to remove by cold snare. The cold revolution is also extending to 10 to 19 millimeter or intermediate sized polyps. In expert hands, cold resection can be considered for most 10 to 15 millimeter sessile polyps and may be reasonable even for larger sessile serrated lesions. Meticulous attention to technique and adequate resection margins are crucial. Hot snare polypectomy is often needed for larger or bulkier adenomas in this size range. Although submucosal injection is frequently used, there is actually little evidence that it is beneficial for polyps less than 20 millimeters. Tattoos can be placed for lesions that might need future localization at endoscopy or surgery. The risk of delayed post-polypectomy bleeding can be decreased by using cold instead of hot resection techniques. For pedunculated polyps size 10 millimeters or more, or with stalk diameter over 5 millimeters, a hot snare technique should be used because of the higher risk of bleeding, and prophylactic measures such as epinephrine injection into the stalk may be helpful. Unfortunately, prophylactic clipping of polypectomy sites does not impact the risk of delayed post-polypectomy bleeding for polyps less than 20 millimeters. Even though we have outlined current best practices for polypectomy, endoscopists should know their limits and not attempt polypectomy if they do not have the technical ability, time, or equipment to complete a curative resection. In addition, polyps that are 20 millimeters or larger in a difficult location or recurrent at a prior polypectomy site may need complex resection techniques with referral to an advanced endoscopy center. Surgical evaluation is recommended if polyps have features suggestive of deep submucosal invasion, such as a nice 3 surface pattern, a non-granular surface pattern, or depressed morphology. To learn more, please read the full article in Clinical Gastroenterology and Hepatology. Thank you.